Patrick Olivieri, and I'm going to talk to you today about 3 treatments that really, really work in cardiac arrest. So first, again, a good talk, my financial disclosures. My parents still pay my cell phone bill. It's just Alright, so today, I'm going to talk to you about the best drugs that work in cardiac arrest that we're not using. I'm going to talk to you about the best device we have that none of us use. And like everything in New York, I'm going to reiterate that location really matters. Alright, so the best drugs we're not using every day. Hopefully some of you have heard of this on a blog, but it's VSE. So these are vasopressin, steroids, and epi. So what is this? It's a whole protocol. For the first 5 rounds, in addition to epinephrine, you get 20 units of vasopressin. And at the very beginning, you start off with 40 milligrams of soluble. Alright, so we get Dr. Mentzelopoulos. This is the older Greek study in an area where AHA takes out vasopressin and no one thinks epi works. He just throws everything at it. So we get vasopressin, steroids, and epi. And we get a number needed to treat of 7 to save a life. Normally, that would be practice changing. We have a couple problems here. So it's a 100-person study. It's 1 center in Greece. And their methods weren't great to show who had a neurologically intact discharge. So we get the New Age Greek study. He fixes all these. So we have 265 people, 3 centers in Greece, and their methods are perfect. We get a number needed to treat of 12 to save a life and walk out of the hospital. A couple caveats so I'm not misleading you guys. These are in-hospital cardiac arrests, which we see some of, but not too many. And it's a whole protocol. So I'm going to give this, and this is something I don't see very often at all. I'm going to give this a pretty good thumbs up with the caveat that it's not the normal population we see. Alright, the best toy we're using. Let me tell you guys that there are 25 human and animal studies saying that we have a device that improves blood pressure, improves perfusion to your brain, and improves survival. So I'm talking about an impedance threshold device, or ITD, and there's 2 different models up here. I don't endorse one or the other. Alright, so normal physiology. I breathe in, diaphragm expands, and that's what lets air in. That negative pressure also lets preload in. Preload dictates cardiac output, we're all happy. Sudden cardiac arrest. We have chest compression in, your chest immediately recoils and air goes in, and there's no room for that preload that helps perfuse your brain and your heart and all that good stuff. So an ITD basically just fixes this. It prevents air from coming in when the chest recoils. You have negative pressure, and you can perfuse everything you need to. So all sounds awesome, right? It's one tiny journal did a study of 8,000 people, randomized ITD versus sham, and we see no difference in mortality. So it's a huge, huge bummer. There's a big group in the resuscitation community that thinks all these treatments that could be really, really great are hindered because our CPR is really, really boring. So they take this study, they look at the 1,800 people who got good compressions, right away. In that 1,800, totally worked. Have an NNT of about 14 to save a life and let someone walk out of the hospital if you use this device versus not. I can't go 100% against a New England Journal of Medicine study, but I'm cautiously optimistic. And I would 100% want this device used. We're going to see a lot more of it. Alright, the only question I'll ask to the audience is where would you want to die? And what I mean by that isn't as morbid, it's if your heart were to stop in one city in the country, where do you think you'd have the best shot of walking out alive? Alright, so I heard someone say this room, which is pretty yes. Let me tell you one more thing. We have a 2004 resuscitation study and a 2008 JANA study of 80,000 cardiac arrests between the 2. Out-of-hospital cardiac arrest survival rate for Chicago, 3.1%. And for Seattle and Kings County, between 35 and 46%. That's a number needed to treat of about 3 to save a life just based on where you flew to that day. So what's going on? This guy on your right is Dr. Leonard Cowan. He trained 100,000 people how to do CPR in the 1970s in Seattle. They have Medic 1 as their paramedic squad. And he basically dubbed the public Medic 2. And they're an extension. They placed AEDs everywhere. And with shockable rhythms, the survival rate goes up to 62% in Seattle and Kings County. That's better than a coin flip. And I think they had an embarrassing 56% last year, compared to about 8 to 9% for the rest of the country. FYI, New York's 6.5%. Every other person, literally 50% of people in the Seattle area know how to do CPR and work in AED. They were the first city in the world to have dispatchers instruct bystanders to do compressions. And they're piloting a study. They have piloted a program where you can get a text alert if someone goes down within a block of you, and you can run and start compressions before Medic 1 gets there. All right, so they teach push hard, push fast, and push often. Little physiology. After 10 seconds, pause and compressions. It takes another 45 seconds to perfuse your brain again. And for every 1 second above that, your mortality goes up by 1%. So 1% pause above 10 seconds. They preach this, they send people everywhere, and there's nothing that works better that we have besides maybe the idea of doing a chest compression and early chest compressions and getting the public involved. I'm going to give this a push hard, push fast fist bump, not just a thumbs up, because it's by far the best thing yet. My last plea is just to all of you guys. No one should be nerdier about resuscitation than ER doctors. And I'd push that no one should be better at it than New York ER doctors. So I'm hoping that we can be the next generation to save more lives than the defibrillator. My last plea, just like Party, give an amazing talk, is this is an incredible fellowship. Please apply. Thank you to all NYC, and thank all of you for your time.